afternoon. I'd like to welcome everybody to the webinar, Active Living During Pregnancy. What do I tell my pregnant client? I would like to start by acknowledging Indigenous people who've been living and working on the lands across Canada for thousands of years, including the land where you're watching this webinar from today. The Health Nexus office in Toronto is located on the historical territory of the Wendat, Petun, Seneca, and most recently, the Mississaugas of the New Credit First Nations. We're grateful to have the opportunity to work in this territory. So as you may have noticed, the session is being recorded, and I would like to briefly explain to you the screen. You notice the main presentation screen, and below that there are some files you can download on the left in French and in English. We've got the key messages for prenatal education, PARked's active pregnancy brochure, the PARmed-X for pregnancy, and also the prenatal education module on physical and emotional fitness from the Best Start Resource Center. And beside that are some links that will be referred to during the presentation. And as you know, you're all muted, but you can ask your questions put your questions into the chat box. And we will have the questions at the end through the chat box. So very briefly, I'd like to go over the key message website that you are hopefully familiar with now. This was developed about 2 years ago to make sure that all service providers who work with pregnant people were giving the same messages. And there are 25 topics on this. And today we will be focusing on the active living module. And as you can see, the key message tab here gives the key messages you should be giving to pregnant people, and Dr. Mottola will be referring to that. All the supporting evidence is available behind it in case you're asked, a little bit more details about it. And then we have resources and links that are available to you, and they've all been, we're maintaining all those links current too. And then in some cases, such as this one, there are appendices and a list of references that are called upon. And if you're not familiar with this website, I also want to point out that you can register for updates using this tab, and then you are informed when there are major updates done. So about every 3-4 months we send a list of updates. Unless there's something very urgent, then we would update it right away and send everybody an email about it. And there are all the key messages also can be downloaded in PDF format. So those could be handouts that you give out in prenatal education. So obviously today would be the active living one that we'll be talking about. And as you can see, there are many experts that developed that website, and Dr. Mottola, who is will be speaking today, is one of the experts who reviewed the modules, or the active living module. While I will close this pod, and while everybody is entering the room, because I see participants are still entering, we will do a quick poll to find out what sector you are from. And while we're doing that, I did look through the registration, and it's impressive that we have 8 provinces represented here today: Ontario, Quebec, Newfoundland, British Columbia, Saskatchewan, Alberta, New Brunswick, and Prince Edward Island. So welcome everyone. And I see that public health is very strongly represented, as in most webinars so far. And we also have Healthy Baby, Healthy Children people, community health representative, and people from early on, which was the early years centers. And that's always nice to see, because they often do give out messages related to prenatal education, even if they're not prenatal educators. So that is very useful to see. And I know we're supposed to have about 100 participants, so I suspect many of them will come in gradually as the session goes on. And so I will go now to the main PowerPoint slide, main presentation, and while it's opening, I would like to welcome Dr. Michelle Mottola, who is the director of the Exercise and Pregnancy Lab at the University of Western Ontario, and probably the key specialist in Ontario on exercise during pregnancy. So we're very pleased to have her present today. So now I'll give the microphone back to Dr. Mottola. Thank you.
Thank you very much, Louise, and welcome everyone. I just wanted to thank Louise as well for inviting me here today. And I think this is a topic very near and dear to my heart. And so I welcome everyone, and I would basically I want to talk to you about active living during pregnancy and what specifically do I tell my pregnant client. So the objectives basically are three. Hopefully at the end of the session today, you will be able to define factors during pregnancy that influence future disease risk in the mother and in the infant. You'll also be able to describe how exercise and a healthy lifestyle, and I think that it's not just active living, but a healthy lifestyle that is important during pregnancy, and these factors together may prevent future disease risk. And then hopefully at the end, you will be able to apply this knowledge to promote a healthy lifestyle and active living for the mother, her family, and also for your community. So I want to start by way of introduction, and I borrowed this from The Economist from way back in 2003, and basically what it's showing us is that potentially there is an issue, a problem with obesity globally, and it affects pretty much every country of the world. And so the question here is, why do we have such an obesity epidemic? And you can certainly relate that to diabetes, cardiovascular disease. There seems to be chronic disease risk that is rampant within our planet. And so it's an interesting dilemma that we have, and I want to share with you potentially some of the ideas that maybe there may be ways that we can maybe curb some of these issues. This slide is interesting because, and in fact, it kind of blows some of my students away when I talk about the egg that formed you was created when your grandmother was pregnant with your mom. And you go, wait a second, what does that really mean? And actually what that means is that the mother here who is pregnant is actually your grandmother, which would be the first generation. And the fetus is your mother that's developing during this pregnancy, and the eggs or the reproductive cells are actually going to become you when your mother as a fetus becomes pregnant. So it's an interesting idea, but what this does show is that indeed we can talk about maybe 2 or 3 generations of individuals that can be influenced by your grandmother's potentially pregnancy. And this comes to the idea of there is a relationship between genes and the environment, and that's similar to that of a loaded gun and its trigger. And that refers to basically epigenetics and potentially fetal programming. So what the fetal environment is like can maybe be predicted for chronic disease risk for both mother and child. Is there a pregnancy link to obesity, in particular in the mother? Yes. Among women of childbearing age, one potential pathway for obesity development is excessive pregnancy weight gain and then that retention postnatally. And because of this, the Institute of Medicine has actually come up with guidelines that would suggest that pregnant women, based on pre-pregnancy body mass index, and you see that listed there on the left. If I can get my pointer to work here, sorry, it's being difficult. There it is. Okay, so along the left here you can see that there's pre-pregnancy body mass index, and this is the body mass index here. And then you can see that what the Institute of Medicine is suggesting is total weight gain in ranges. And I've listed them in pounds and actually in kilograms. And you can see, for example, that a normal weight woman should be gaining no more than 35 pounds or 16 kilograms. Overweight women, no more than 25 pounds or 11.5 kilograms. And obese women, no more than 20 pounds or 9 kilograms. The other thing that you'll see here is that the Institute of Medicine also provided rates of weight gain for the second and third trimester, and again listed in pounds here, and on the side is kilograms. And the other thing to point out here is that all of these calculations assume that a pregnant woman should gain no more than 4 pounds or 2 kilograms in the first trimester. And so excessive pregnancy weight gain is actually a modifiable risk factor, and it can be linked to type 2 diabetes later in life, especially if she has gestational diabetes during pregnancy. If she has hypertension, pregnancy-induced hypertension, she can potentially be at risk for hypertension or cardiovascular disease later in life. And weight retention, if she retains a lot of weight, she can actually also be at risk for obesity and comorbidities. And so my colleagues, my obstetric colleagues, would suggest that they no longer see, or very few of them see, normal weight pregnant women. In fact, what they actually are seeing are more and more pregnant women who are overweight and obese. And that comes down to this scary statistic where you think that 1 in 6 pregnant women are obese and 1 in 3 are actually overweight. So I'm a visual person, and so what I believe is that there is a cycle of obesity that takes place. And when you think about the mother, we know that potentially overweight and obese women may partner with overweight and obese men. And if these women have issues with weight loss, or are not successful with weight loss before pregnancy and have an unhealthy lifestyle, and they do go on and gain excessive weight of greater than 11.5 kilograms if they're overweight, or 9 kilograms if they're obese, and they give birth and then retain that weight, and we know that potentially they can retain weight from previous pregnancies of about 13 kilograms. And then if you think about this cycle of obesity, if she gets pregnant again, you can see how this can spiral. The other thing to remember here is that even normal weight women can enter into this cycle if they gain more than 16 kilograms. But I also believe that there is a baby cycle of obesity, and this can come through with women who gain excessively because they are more likely to give birth to a baby who is big, baby that is over 4 kilograms, macrosomic, or too small, which would be less than 2.5 kilograms. And if you look at what might potentially happen with these babies who are too big or too small, they can be more at risk for childhood obesity, diabetes, cardiovascular disease, and in the next generation with these children, if they actually do, if they're female anyways, and they actually do become pregnant, then they could have pregnancy complications, and again, they would enter into this adult cycle of obesity. So it's interesting when you think about this, especially with regards to fetal programming, and there is a large body of literature that is called The Developmental Origins of Health and Disease, and that is actually a potential issue with regards to chronic disease risk for both the mother and the developing child. So in this diagram here, you can see that this is newborn birth weight along this axis here, and you can see there's normal birth weight and babies born small on this end, and babies born big on this end. And what this shows you is a U-shaped curve that indicates an increased health risk for the fetus or the offspring if the babies are born small or born large. And I would suggest that potentially, because we're seeing more and more big babies, that maybe this is actually more of a J-shaped curve where we see individuals that are born big. So the other thing to think about here is when you look at babies that are born small, those babies born small actually have a rapid rate of catch-up growth in the postpartum period in the first year of life. And because of this accelerated or rapid rate of catch-up growth, these babies put on visceral fat, which is the worst type of fat to put on, as you know, that is at risk for cardiovascular disease. And these babies in childhood and future adults can be at risk for obesity, diabetes, and cardiovascular disease. Also, those babies born big are at risk for childhood and adult obesity, diabetes, and metabolic syndrome. So there appears to be trouble on both sides of the birth weight spectrum. I just want to share this example with you here. It's very interesting. This is actually based on a rat study, but I thought it was interesting and I'd like to share this with you, that maternal ingestion of junk food or heavily processed or hyperenergetic food during pregnancy and during lactation may increase junk food preference of the offspring and may increase the risk for offspring obesity. And I thought that was a very interesting study, and I just wanted to share that with you because it does come back to this idea of fetal programming and the developmental origins of health and disease. The other thing I want to share with you here is the fact that timing of excessive pregnancy weight gain and offspring adiposity may be linked. So we did a study a number of years ago where we had 172 women. 34% of them were normal weight, 34% overweight, and about 33% of them were obese. And we looked at weight gain before mid-pregnancy at 16 to 20 weeks up to that midpoint. And then we also looked at them from that midpoint to delivery. We looked at those women who gained appropriately up to mid-pregnancy and beyond versus those that gained excessively, and it was based on their body mass index category. So we divided these women into those that gained appropriately prior to mid-pregnancy and those that gained appropriately after to delivery, those that gained appropriately to mid-pregnancy and those that gained excessively from mid-pregnancy to delivery, those that gained excessively up to mid-pregnancy and appropriately after, and then those women that gained excessively prior to mid-pregnancy and also up to delivery. And then we compared those women with their infant birth weight and their adiposity. And normative neonatal or newborn body fatness is about 12 to 14%. So what I want to share with you here is what we found in this particular study. So what you can see here in this top graph is when you look at neonatal body fatness, which is this along this axis here, and we divide the women by what they've gained, so appropriate gain up to mid-pregnancy and appropriate after, so we've called these women appropriate gainers, appropriate before and excessive after mid-pregnancy, late excessive, versus those women that gained excessive early and appropriate after mid-pregnancy, and then those women who gained excessively both early and beyond. And what you can see from this graph is that those women that gained early excessive actually gave rise to neonates that had a higher percent body fatness. And if you also look at this graph down here, again, neonatal body fatness is on this axis. We've divided them into those women that gained excessively late and those women that gained excessively early when you look at total weight gain. And again, the same thing happened, that those women who gained early excessive also gave rise to babies that were fatter at delivery. So what this potentially means is that the timing of excessive maternal weight gain, specifically during the first half of pregnancy, is a stronger predictor of infant body fatness at birth than total maternal weight gain. And in fact, pre-pregnancy body mass index did not matter in this particular study. So the interesting thing about excessive gestational weight gain, as I've mentioned, is it's modifiable. It's linked to obesity. It's linked to gestational diabetes. And actually, when you think about it, what can be the link for all of these things is physical inactivity. And physical inactivity can be linked to chronic disease risk for both mother and downstream effects on the future child. And we're specifically looking at type 2 diabetes, cardiovascular disease, and metabolic syndrome. So if excessive gestational weight gain is a modifiable risk factor, then what would happen potentially if we were to have appropriate weight gain? And we can do this with physical activity. And so then what we end up with is we can maybe prevent obesity, we can prevent gestational diabetes during pregnancy, and we can modify and maybe prevent chronic disease risk later in life for both mother and future child. What are some of the effects of exercise during pregnancy? And so I'd like to share a few studies with you to show you that indeed, when you look at exercise and association with a reduction in gestational diabetes, for example, this study was in women that were not at risk for gestational diabetes, but what this particular study showed with a randomized controlled trial, that there were 101 women in the intervention group that exercised versus 156 control women. And what this study shows is that 35% of the control women gained excessive weight, whereas 23% gained excessive weight in the intervention group. There was a reduced incidence in gestational diabetes, 9% in the control group versus only 1% in the intervention group. And the exercise program was well attended, so greater than 80% of these women actually attended exercise, and I'll talk a little bit about compliance or attendance later. But this exercise program was given 3 times per week for 50 minutes each session with an intensity of about 60% predicted heart rate reserve. And they used a mixture of aerobic and muscle conditioning exercises on both land and in the water. So the point of this study is that yes, indeed, exercise may reduce gestational diabetes. If we take a look at another study here. This one is looking at exercise that may protect against hypertension and big babies. And again, this was a randomized controlled trial that had high attendance, greater than 80% attendance. And what I want to share with you here are 3 main things. The first one is that if you look at hypertension, those women without exercise during pregnancy are 3 times more likely to develop hypertension. They are 1.5 times more likely to gain excessive weight and are 2.5 times more likely to give birth to a macrosomic infant. And those are women who do not engage in exercise during pregnancy. The last study I want to share with you here is actually a systematic review meta-analysis where they looked at supervised prenatal exercise and the effects on fetal growth. And what they found was that structured prenatal exercise reduces the odds of having a big baby by 31%. There was no evidence to suggest that prenatal exercise alters the odds of a small birth weight baby or a preterm baby. And maternal exercise decreased weight gain by 1.1 kilograms and decreased the odds of a C-section by 20%. So I'm sharing these studies with you because I think they have important messages with regards to the importance of exercise during pregnancy and preventing chronic disease risk. I don't have to tell you that healthy lifestyle is actually a balance. It's a balance between eating healthy, and I usually suggest that pregnant women not eat for two, but actually eat twice as healthy. And it's important when you think about portion sizes. And I'm going to talk about eating habits and nutrition a little bit later. I'll come back to this. What I want to also focus on is the other side of the equation, which is physical activity. And pregnant women should no longer be told that they should rest during pregnancy. So the question here is, if we can restore the balance with physical activity and eating habits and promote active living during pregnancy, can chronic disease be prevented in future generations? And I think that's a really important question. So how do we promote active living for pregnant women? Pregnancy is actually a time when many women change to a healthier lifestyle. They improve their eating habits. Sometimes women may not have had breakfast, but now that they're pregnant, they think about actually eating breakfast in the morning. They may think about quitting smoking, stopping alcohol use, moderate their caffeine consumption, and they may think about active living. And the fact that they're maybe thinking about this is an important component for behavior change. I want to just share with you a few studies that I've found when we look at how many women are actually being active during pregnancy. This particular study, there were 70% of women that were engaged in a structured exercise program before pregnancy, but this dropped to 49% in trimester 3. During pregnancy, all categories of activity decreased except walking, which actually increased in trimester 3, and I'll talk about walking later. And the factors that were associated with quitting a regular structured exercise program by trimester 3, no surprise here, having children, and actually lack of time was in there as well. Pre-pregnancy body mass index of over 25, so overweight and obesity, or higher weight gain. Interesting. If you look at the next study here, this study found 471 women that were followed mid-pregnancy and late pregnancy, and they looked at mode, frequency, duration, and intensity of all physical activity that increased breathing and heart rate in the past week in those two time points. And what they found was that physical activity decreased from mid-pregnancy to late pregnancy. My pointer's giving me a problem. Okay. The next study that I want to share with you is Gaston and Cramp, where they found that pregnant women are less active than non-pregnant women, and pregnancy leads to a decrease in physical activity. And in this last study here, 50% of the women interrupted practicing exercise due to pregnancy. Lowest prevalence of exercise was observed in the first and third trimesters. And again, walking was the most commonly reported exercise, followed by water aerobics. And about 50% of these women, less than 50%, received exercise guidance during prenatal care meetings. So the point I'm making about this is that it does appear that we have work to do to try and keep pregnant women engaged in physical activity. There are guidelines that are out there. I want to share with you some of the guidelines that are the most used guidelines. The first one here is from the American College of Obstetrics and Gynecology. And this was actually presented in December 2015 and reaffirmed again in 2017. And the bottom line for these guidelines is that physical activity and exercise is important, And the eventual goal of moderate intensity exercise is for at least 20 to 30 minutes on most or all days of the week. And they suggest that these guidelines or this exercise goal be developed with the patient and adjusted as medically indicated. In Canada, there have just been reaffirmation of the Society of Obstetrics and Gynecology of Canada's clinical practice guidelines from 2003. And the disclaimer here is that this clinical practice guideline was peer-reviewed and has been reaffirmed for continued use while the revision is underway. And I can tell you that we are currently in the process of revising the clinical practice guidelines, and we hope to release them in the fall of 2018. And I can't give you any information yet, so stay tuned, but we should be able to, and hopefully will be releasing these in the fall of 2018. But in the meantime, these 2003 guidelines have been reaffirmed in February of 2018. So there are key factors that I want to share with you with regards to exercise prescription. One of them is, I think, really important: start slow, go slow, aim high. And before prescribing physical exercise or exercise prescription, you must take a look at her history. So medical screening is important, and I'll talk about this in a minute. What is her pre-pregnancy body mass index, her age, her fitness level, her occupation, and what actually does she want to do? So I think these are really important things that you need to think about before you prescribe exercise to your pregnant client. And the best way to do this is to take a look at the PARmed-X for pregnancy. And the PARmed-X for pregnancy is based on the clinical practice guidelines, Canadian clinical practice guidelines. And this tool was revised in 2015, and you have it, and I see that it is a file that you can actually download. And I would suggest that you do that if you haven't already, because what I'd like to do is to share this tool with you so that you can prescribe physical activity using the PARmed-X for pregnancy. So we're going to go through each of these 4 pages. It is a 4-page document. It is a medical pre-screening form, and it does contain the Canadian guidelines for exercise during pregnancy. You can download it from that website, and hopefully you've done that already. But the idea of this 4-page document is to open the communication between the fitness professional, the healthcare provider, and the pregnant client. So that was why this was originally put together. Now, page 1 is important because the pregnant client actually fills out page 1. So she fills out page 1, and I just want to focus here on page 1. You'll notice the top is instructions on how to use the form. Your client can fill out this top part A, and then this last part here, part B, asks her about her previous physical activity. Over here, physical habits during the past month, and I'm going to talk about this in a minute. Her occupation, which I think is really important, and her intentions, and that's listed here. What do you intend to do? And the reason why I think that all of this is really important, I'm just going to go back for a minute, is because, for example, if you have a pregnant client who maybe is a nurse, who is on the ward, runs up and down the ward, lifts patients potentially, and you say to her, do you exercise? She'll say, oh, I don't have time to exercise, but in fact her occupation may actually have a large amount of physical activity within it. So before you prescribe physical activity, you don't want to overly fatigue your pregnant client. You need to find out exactly what it is that she does for her occupation. Even a pregnant client who may have children at home that are all under the age of 5, if you ask her, do you exercise? She'll say, oh, I just don't have time to exercise. But in fact, she's probably lifting toddlers, or she's maybe running up and down the stairs, lifting laundry baskets, etc. And she may not realize that she actually is doing a fair amount of physical activity during her everyday life. So before you prescribe, it's very important that you take a look at what she does during her daily activity. So page 2 here is, at the top of the page, is a medical pre-screening form in checklist format, and it is for the healthcare provider to complete. You'll notice that there are absolute contraindications and relative contraindications. I'm not really going to go over that because that is up to the healthcare provider. But the bottom line here is that physical activity can be either recommended or contraindicated. Also on page 2, you'll notice that there is this big area here for prescription for aerobic activity, and I want to spend a little bit of time on this. So frequency, intensity, time, and type is the FIT principle that should be used for any type of exercise prescription. And so you'll notice here, and this is on the bottom part of page 2, I've just made it bigger for you, is frequency, begin at 3 times per week and progress to 4 times per week. Now, if pregnant women have a low-risk pregnancy, they can, and never exercised before, they can begin at 3 times per week and progress to 4 times per week. And I'll talk about frequency in a moment. Intensity, I'll also talk about in a minute. Intensity is extremely important. Time, attempt 15 minutes, especially if she's never exercised before, and work up slowly to 30 minutes, even if it means reducing the intensity, and I'll talk about that in a moment. And the type of activity, non-weight bearing or low impact endurance exercise using large muscle groups. For example, walking, stationary cycling, swimming, aquatic exercise, or low-impact aerobics. And I am reminding you that walking is a marvelous aerobic activity, and it seems to be actually what most pregnant women want to do. And we'll come back to walking in a moment. So basically, in this area of page 2, you'll notice that there is a rate of progression. So the best time to progress is during the 2nd trimester, when the risks and discomforts of pregnancy are lowest. Many pregnant women may tell you that they've got morning sickness, which can happen any time during the day or night, or they're so tired that they can hardly lift their head off the pillow. And so for you to prescribe exercise for them during that time point in their pregnancy may not be a good idea, because compliance is important. So it may be best for you to prescribe physical activity maybe during the 2nd trimester, when she actually does feel human again, and that may be a good time to prescribe and progress. So she can progress from a minimum of 15 minutes per session 3 times per week at the appropriate target heart rate, and I'll talk about that in a moment, to a maximum of approximately 30 minutes per session at that specific target heart rate, up to 4 times per week. And again, that depends on how she's feeling. So just because you may be prescribing activity in the 2nd trimester, it is a rolling prescription, because pregnant women in the 3rd trimester may start feeling more tired, and you may have to back off on the intensity. So it is a rolling prescription. The other thing I'm pointing out here is that pregnant women should have a 10 to 15 minute warm-up followed by a 10 to 15 minute cool down, because it's important that pregnant women warm up slowly, because it takes them just a little bit longer to warm up to their aerobic activity. So I'm going to spend some time now on the FIT principle, and in particular focus on intensity. With regards to intensity, there are 3 ways to check intensity. The first way is to look at target heart rate. Now, these target heart rate zones were developed from pregnant women. The other target heart rate zones for non-pregnant women may not be appropriate because resting heart rate in pregnant women increases about 15 to 20 beats per minute above their non-pregnant values. So it's important, if you are prescribing heart rate, that you focus on these particular target heart rate zones because they were developed from pregnant women. So these target heart rate zones are based on age, so 20 to 29, 30 to 39, less than 20 years. It is also based on fitness level or body mass index, and you'll notice that low fitness, active fitness, recreational, or very fit, and these are the target heart rate zones based on fitness level. And there's a separate category for those women who may be overweight or obese and have never exercised before. And they are at a little bit lower target heart rate because their activity may be more mild activity, perhaps walking, for these women because it's very important for compliance and it's very important that they stick with their physical activity program. For example, if you have a woman who's never exercised before, she's 35 years old, you probably would look at this particular category of low fitness level, and so the target heart rate range is there for a reason. So you may start her at a lower target heart rate zone of about 128 beats per minute, and depending on how she's feeling, you can increase that intensity so you make sure that you don't overly fatigue her. So that's the first way. The second way is the rating of perceived exertion scale. So it's important that you, if you can, ask her how hard she's working. And if she is within the range of somewhat hard, 12 to 14, that's a good thing. So she's working a little bit harder. The third way is the talk test. So if she can carry on a conversation while she's exercising, it's a wonderful opportunity to determine her intensity. If she's out of breath and she cannot carry on a conversation, her intensity needs to be decreased. So those are the three ways that you can check intensity. Page 3 looks at muscle conditioning. And the top part here are examples of muscle conditioning exercises. I'm not going to spend a lot of time on that. Those are just examples. What I do want to spend some time on are some of the precautions for muscle conditioning activity. And at the bottom of this page, you'll notice a little scissor that runs across. And that is, with this document, that can be cut, and the physician can actually put an indication here of her pregnancy. For example, if she has had high blood pressure in the past, the physician may, or the healthcare provider may want you as a fitness professional to look at her blood pressure potentially throughout her pregnancy. So it's a way to increase the communication between the healthcare provider, the pregnant woman, and the fitness professional. So these are examples here, as I've mentioned, of muscle conditioning, muscle strengthening exercises. I'm just going to point out the fact that Kegel exercises or pelvic floor exercises are very important for pregnant women, and that's all I'm going to say about that. I don't have time today, but certainly that it will definitely strengthen the pelvic floor. What I do want to focus on are precautions for muscle conditioning. So there are basically 5 precautions, and I'd like to go through each of these 5 separately. The first one on the list here is body position. So body position, basically it's because of the effects of pregnancy. And because of the effects of pregnancy, there is a caution with regards to supine positioning. So lying on the back, the enlarged uterus may either decrease the flow of blood returning from the lower half of the body as it may press on the inferior vena cava, or it may decrease flow to a major artery, the abdominal aorta. And I'm going to show you a diagram about that in a moment. The exercise modification suggested is that past 4 months or 16 weeks of pregnancy, exercises normally done in the supine position should be altered. And the suggestions here are abdominal exercise can be done standing, they can be done sitting, they can be done lying down on their side, so they can do abdominal crunches but lying down on their side. So getting away from that supine position. And the reason is because if you take a look at the diagram here on the left, you can see that there's the position of the inferior vena cava and there's the pregnant uterus. There's no restriction in blood flow. But as soon as you put that pregnant client on her back and exercising, there is the potential here that the pregnant uterus may restrict blood flow. So we do not know for sure, but we err on the side of caution. And so that's why past 16 weeks, pregnant women are suggested to not exercise in that supine position past 16 weeks. The second precaution here is muscle conditioning is joint laxity. And again, this comes back to ligaments become relaxed potentially due to that increase of hormone relaxin, and the joints may be more prone to injury. And so these exercise modifications are to avoid rapid changes in direction with bouncing, and stretching exercises should be performed with controlled movements. Again, this is probably common sense. The third precaution is regards to abdominal muscles. There is a condition that may develop called diastasis recti, and if this condition does develop where there is actually a presence of a rippling or bulging of connective tissue along the midline of the pregnant abdomen, your pregnant client will tell you about this, because anytime she does an increase in abdominal pressure, she will see that rippling along that linea alba or midline, and she will bring that to your attention. If that condition does develop, abdominal exercises are not recommended. So she can, however, begin abdominal exercise once the baby is born, but during pregnancy, we recommend no abdominal exercise if diastasis recti develops. And let me show you why. So in this little picture here, you can see that there is the rectus abdominis muscles with the linea alba straight down the midline in a non-pregnant condition. In a pregnant condition, what can potentially happen is with the protrusion of the abdomen, you're going to get a tearing of the linea alba connective tissue at the weakest point. If you continue to strengthen those abdominal muscles, that abdomen is still going to get bigger, and you may potentially make that condition worse because it's still going to tear at the weakest point. So we again err on the side of caution. If this condition does develop, we suggest no abdominal exercise until after the baby is born. The next precaution is posture, where the effects of pregnancy with the increased weight of the enlarged breasts, the uterus may cause a forward shift in the center of gravity and may increase the arch in the lower back. Also may cause the shoulders to slump forward. Many pregnant women have terrible posture. And so what we suggest here is that with regards to correct posture, shoulders in line, and the pelvis should be placed in a neutral pelvic alignment. So let me show you with my next picture here what that actually means. So what what this picture is showing you is a pregnant woman standing with her feet shoulder widths apart, knees slightly bent, head raised, shoulders back. And basically, the idea here is to be careful of a posterior pelvic tilt position where she actually pushes through, the pelvis pushes through. We don't want that position. We also don't want that lordosis position where she accentuates that lordosis curvature of the spine. What we do want is a neutral pelvic alignment halfway in between those two extremes. And that's what we promote with regards to correct posture. The last point here with regards to precautions is resistance exercise or weightlifting. So emphasis should be placed on continuous breathing throughout the exercise, exhale on exertion, inhale on relaxation using high repetition and low weights, and we usually suggest about 12 to 15 repetitions. The Valsalva maneuver or holding your breath is not suggested during this activity because it may change blood pressure and should be avoided. And of course, the other thing is to avoid exercise in the supine position past 4 months or 16 weeks of pregnancy. So those are the 5 precautions for physical activity with regards to muscle conditioning. So the other side of this page 3, again, as I've mentioned, is the communication between the healthcare provider, the fitness professional, and the pregnant client. Page 4 is advice from the Public Health Agency of Canada, and at the bottom here is safety considerations and reasons to stop exercise and consult a healthcare provider. So I do want to spend a little bit of time on those. So in this slide here, it's just showing you safety considerations, but as a little bit bigger. And again, these are common sense. Avoiding exercise in warm, humid environment. Avoid isometric exercise or straining. Maintain adequate nutrition and hydration. Sipping fluids before and during and after exercise. Avoid exercises lying on your back. Avoid activities which involve physical contact or danger of falling. And I've highlighted this next one here because pregnancy is not a good time to train for athletic competitions. So we usually suggest, because we're erring on the side of caution, we do not know what the impact is on with pregnancy and competition. So we suggest that pregnancy is not a good time to train for athletic competition, and to know the reasons to stop exercise and consult a qualified healthcare provider. And those reasons are listed here and are, again, common sense. If any of these things occur, the woman is to stop exercise immediately and consult a healthcare provider. So to summarize the Canadian guidelines that are out there right now and the PARmed-X that I've just told you about is that previously sedentary women with healthy pregnancies can safely start an exercise program in the second trimester. Start slow, go slow, aim high. Women with low-risk pregnancies can continue mild to moderate physical activity throughout. Mild to moderate aerobic activity within the Canadian guidelines is considered safe, and muscle conditioning activity with necessary precautions is also considered safe. Now, what I do want to spend a little bit of time on here is those women who are extremely fit. Those would be elite athletes or very fit women. And I was fortunate enough to be invited to Lausanne, Switzerland by the International Olympic Committee, and this is our group here. And basically, we convened in 2016 to take a look at the literature with regards to women who were elite athletes, and also looking at those highly active recreational athletes. And there are now going to be 5 parts to this. And one of the things that I can tell you is that there were very few studies on elite athletes. And so there actually is now 4 parts that are published in the British Journal of Sports Medicine, and the titles are listed there. Number 5 is going to be published later on this year in 2018, and that actually will be recommendations from the International Olympic Committee for elite athletes. And again, they will probably be very close to what I'm going to be mentioning to you in the next couple slides. So one of the things to think about here with regards to those women who are very active or elite athletes is intensity, frequency, intensity, time, and type of physical activity. I have a cautionary note here of frequency. Be cautious of those athletes or women who want to exercise vigorously for 5 or more times per week because of fatigue. It may be better that they have potentially days of lower physical activity in between their higher physical activity. And so be cautious of those women who do want to do 5 or more times per week. Also, intensity, think about the talk test, and also think about these target heart rate zones for women that we've put together that were fit. And you'll notice that there actually are higher target heart rate ranges here for fit women, depending on age. Use this for your pregnant athletes because we know that these particular guidelines are safe for low-risk women. And also duration. I'd like to talk a little bit about that because 30 minutes may not do it for these women who are recreationally very fit. So what I usually suggest to these women is, okay, let's talk about duration. You can warm up for 10 to 15 minutes. You can exercise strenuously within the target heart rate zones at your target heart rate for 30 minutes, and then you've got a 10 to 15 minute cool down at the other end. So really you are actually working out for about 60 minutes. So this is the way that we have used these guidelines because we know that that is safe for pregnant women. I'd like to kind of take a look at the other end of the continuum here with regards to walking. I think walking is a marvelous activity. I think it's something that is very good to promote. And indeed, one of the things that you can do in your community is to promote community walking programs. And I don't know, but many of you may have mall walking programs in your community already, where early in the morning there's mall walking with the elderly. Why not engage pregnant and postpartum women to mall walk with the elderly or the retired individuals? Let's combine these generations together. And the other thing that you can do, and it's worked really well for us, is to think about overcoming barriers. Excuse me. And in order to do that, what you can do is either include pregnant women and their children in the walking program, or you can include childcare. So one way that we've accomplished this is to reach out to the high school students in your area and get them to help you with volunteering. So they can actually help with childcare while the pregnant woman goes around either mall walks or in her community, engages in walking while her children are in good care as a group with high school students that want to get their volunteer hours. So it's a wonderful way, wonderful opportunity to engage the community. One thing that I do want to emphasize here is once you do have pregnant clients and you have promoted physical activity, is you've got to keep them engaged. We need to do a lot of work here to keep pregnant women engaged in physical activity. I showed you the literature that's out there where pregnant women drop off. And so what we can do potentially is to keep them motivated, keep them accountable, weekly face-to-face if you can, either through social media, however you can engage them, even every other week. You need to keep them motivated and engaged. Pedometers are a wonderful opportunity. They're a great motivator, and it is a great way to engage pregnant women. Other technology tools that you can use, anything that counts steps that they can wear on their wrist, any kind of download phone app they can engage in. Text messaging is also a good promoter of physical activity. Anything else that you can use in your community that will enhance and promote healthy physical activity habits is a marvelous way to engage pregnant women. And they will listen if you take the time to help promote physical activity. Now, the other thing is that we've just talked about prescription for only 30 minutes. I need you to think about what she does during the day and the other 23 and a half hours. So it's really important when you think about daily physical activity. What does she do? And so there are 2 videos that you can find here under web links that I think is really exciting. It is these videos are from Mike Evans. One of them is called 23 and a half hours, and the other one is called How to Make Your Day Harder. Now, you can use this for any client that you have to promote physical activity and to promote an increase in daily activity, but you can also use it for pregnant women. So I suggest that you take a look at these 2 YouTube videos. It's a wonderful way to share this with your pregnant clients, and hopefully they will take this to heart. Other ways that your pregnant clients can be physically active, and one of the things that Mike Evans talks about is to increase your step count. So increase the steps taken per day. Park farther away, take the stairs, use pedometers as a motivator. And one of the things that I think was a terrible thing that happened was with our grocery stores, they have parking slots for pregnant women right close to where the entrance is to the grocery store. I tell my pregnant clients, do not use that, do not park there. Take the farthest spot you can because I want you to increase your step counts. And Mike Evans talks about that as well. Pregnant women can rake the leaves, they can cut the grass, they can garden, they can even shovel snow as long as they watch their technique. But it's a marvelous way to promote physical activity, and many of these women's partners say, yay, that's exciting. They can actually engage with their pregnant women in doing all of these fun activities. And of course, the last thing here is encourage your pregnant clients to play with their children. Again, it will engage the family in promoting physical activity. The other thing that you can get your pregnant women to do is to check out their cupboard. Usually they have huge, gigantic cans of tomatoes in their cupboard, and they can use those for muscle conditioning activity if they are reading a book or any type of sitting activity. They can actually use those cans of tomatoes for physical activity or muscle conditioning, or when they're watching TV. So again, another way to promote daily physical activity. The other thing I want to share with you here is something that the Canadian Society of Exercise Physiology came up with. It's really exciting, I think. Guidelines for optimal health benefits for children and youth aged 5 to 17 years. Now, I know that you are going to be looking at pregnant women, but I just want to take the opportunity here and to talk about this particular guideline. I think all of their guidelines are great, but this one in particular is a 24-hour movement guideline for children and youth. And the reason why I like this is because it's divided up their day, 24 hours, into 4 categories. Sweat, which is moderate to vigorous physical activity. Step, which is light physical activity. Sleep, which is very important for pregnant clients. And reducing sedentary behavior or sitting time. And so they've used this as a wonderful way to look at 24-hour movement guidelines. So you can talk to your pregnant client about this, and you can say, okay, you've engaged in 30 minutes of moderate to vigorous physical activity. What do you do the rest of the day? And look at step counts and sitting activities. Break up the sitting time. There is literature out there that would suggest that sitting throughout the day may actually be very bad for us with regards to chronic disease risk. And that's in the non-pregnant population. So let's take that to heart and let's talk about this with regards to our pregnant clients. Many of them sit throughout the day. So let's break up that sitting time and get them to go for a walk. The other thing that I'm going to promote here is the Move for Two DVD that was funded by the Middlesex London Health Unit that was released in January 2011. And this is, again, a marvelous opportunity for something called a Move for Two. And it basically the objective was to provide safe exercise guidelines for pregnant women in the privacy of their own home. It is based on the PARmed-X for pregnancy, and every DVD does have the PARmed-X for pregnancy within it. And there are different chapters that the pregnant woman can develop on their own. So the offerings here are chapters for intensity. There's low, moderate, or high. And there are duration options here. There's a warm-up chapter, aerobic cool down, muscle conditioning, and flex and stretch. And this is given to prenatal classes at the Middlesex London Health Unit. And I just want to share this with you because if you're interested in ordering these DVDs, the website is actually listed here as part of an order form. And I think this is, again, another opportunity to promote physical activity for pregnant women in the safety of their own home. So the other thing I want to mention to you here is that basically we've talked about intervention, we've talked about preventing excessive gestational weight gain and the prevention of chronic disease risk in both mother and baby. And in particular, we've talked about a little bit about eating habits, mainly focused on physical activity and the fact that, yes, there's little feet with big responsibility here that pregnant clients need to be aware of during their pregnancy. And so coming back to this, looking at eating habits versus activity, it's very important to provide this healthy fetal environment early for the next generation. And what I want to focus on right now are eating habits, which I haven't really talked about yet. And I also want to suggest to you with regards to prescription or intervention. So prescription to me means following those guidelines where you're looking at potentially 30 minutes of physical activity. Intervention to me means looking at total activity throughout the day, but also looking at healthy eating habits. And so I do want to share a little bit of information for you with regards to what happens during those 24 hours. So healthy lifestyle, as I've mentioned, is eating healthy, but not eating for two, but eating twice as healthy. And so what's worked really well for us is talking to pregnant women about portion sizes. And the best way to do this is to have them look at their hand. So they can carry their hand with them wherever they go, whether they are eating at work, whether they are eating in a restaurant, they can look at portion sizes based on their their hand. So we suggest to pregnant women, and this is all guesstimation, but approximately the palm of their hand is equivalent to about 3 ounces of meat, fish, or poultry. A fist is equivalent to about a cup. A thumb is equal to about a tablespoon, and a thumb tip is equivalent to about a teaspoon. And we suggest to our pregnant women actually the gestational diabetic diet. And we found that this works really well with normal weight, overweight, and obese pregnant women as a prevention tool for gestational diabetes. And we have found that working within the guidelines of the gestational diabetic diet, where carbohydrates are controlled and pregnant women actually eat smaller meals more often throughout the day, is a really important thing to help prevent excessive gestational weight gain and also to prevent gestational diabetes if you use that in combination with physical activity. And I'll talk about physical activity in a minute. The other thing that we talk to pregnant women about, and I think education is key, is looking at the sugar content of foods. I had nutrition students that developed this for me, where they looked at the amount of sugar in things that people eat. For example, this is showing the amount of sugar in a soft drink cream soda, 50 grams of sugar. And seeing is believing when you look at this particular item. Even Tim Hortons lattes, it's incredible how much sugar is added into any of those delightful beverages. Looking at chocolate milk, maple syrup, whole wheat bread, and comparing that to potentially what you would see if you do eat healthy, looking at vegetables and fruit. Also, educating women on nutrition facts. Everything has to have a label now, so let's get our pregnant women educated in labels. So what it is that they're eating, looking at the amount, and looking specifically at carbohydrate, sugars, and fiber. And that helps and works really well when you look at the gestational diabetic diet. And that gestational diabetic diet works really well in conjunction with a walking program. And so we have women that have walked 3 to 4 times per week using pedometers. Mild walking program actually works really well. We get them to use a pedometer, and we've started them walking at 25 minutes, and we increase their time walking by 2 minutes per week until they reach 40 minutes, and then they maintain that time. And the object or the reason why we're doing it that way is because we found that most pregnant women actually take about 56, 77 steps. And that places them, if you look at the activity index, between sedentary and low active. And so by starting them at 25 minutes of walking, they are actually increasing their step counts by about 2,800 steps. And when they increase that step count slowly to 40 minutes, they've increased their daily step count to about 4,400 steps. And if you do the math and add that together, you're actually getting them up to 10,000 steps. And so the idea of this healthy lifestyle program that I've just presented to you is healthy eating, potentially using the gestational diabetic diet in combination with a walking program, and that works really well in helping pregnant women to prevent excessive weight gain and to prevent gestational diabetes. So I want to end off here with, I borrowed this from Ann Geddes. My business is to grow healthy babies, and I do that by looking at healthy mothers. Healthy mothers equals healthy babies that will give you healthy communities and healthy futures. And I firmly believe that active living, healthy lifestyle will make a difference not only for 2 generations, but maybe even 3. So I've put 2 generations in quotation marks, but certainly you can make a difference if you are able to engage your pregnant clients into a healthy lifestyle and active living. and I will end it there. I would like to acknowledge all of my graduate students. I would like to acknowledge funding sources, and I will leave it at that. Thank you very much for your attention.
Thank you very much, Dr. Mottola. I can just hear your passion coming through even in a webinar, and thank you for providing great evidence-based information. A couple of questions have come up on the chat line, and we could perhaps address those. One of them was asking if there was a low literacy or less wordy version of the PARmed-X for pregnancy, and somebody, Audrey, responded that, yeah, no, that's a standard CSEP document, but there might be promotional resources. I know I'm aware of like PARC, the Physical Activity Resource Center, has the active pregnancy brochure that is lower literacy for sure, and CSEP also has a document on their store, the Active Living During Pregnancy, but perhaps you are aware of something else, or actually I'm going to open up the chat line wider so we can all see the question, and maybe if you have any suggestions, answers, you can
Okay, those are
jump
great
in.
questions. And I can't, somehow, Louise, I can't see, oh, I cannot see what you've just put in front of everybody. I've just got,
Oh, I'll
okay,
restore it back then.
okay,
I'll
all
restore
right,
it back. I'm
no
sorry,
worries.
I thought
Oh, there it
maybe
is. Okay, I've got it now. Thank you.
okay.
Okay, technical difficulties here. Okay, I think that's a great question. The PARmed-X, as I've mentioned, is not necessarily for the pregnant client. It is a document that that 4-page document was created for the healthcare provider and the fitness professional. And so, yes, I think that's a great thing that pregnant women should have more of a lower key thing to take a look at, and that's where PARC came in. The active pregnancy guidelines are there for a reason. They are, I think, at the level approximately of about grade 8 level, but they are based on the PARmed-X, which is then based on the clinical practice guidelines. And we will be updating the PARmed-X for pregnancy based on the clinical practice guidelines. So it's kind of like a ripple effect, that once the guidelines are updated, then the next thing that will be updated would be the PARmed-X. Then the next thing that will be updated will be active living during pregnancy documents that every pregnant woman can take a look at. And I think one of the things that we do really have to emphasize here with active living is this whole idea of what do you do in that 24-hour period? And so I think as we're engaging in updating the active living guidelines, I think that's where we have to really emphasize the daily living, daily physical activity part of active living.
Right, and thank you. And yeah, so definitely low literacy versions are always useful, but also the key messages from that we've developed through the Prenatal Education Key Message website could be, they are designed to be lower literacy documents that would just have the summarized information. There's another good question from Leanne. Does anyone know of a free or low advertising pedometer app or free pedometer program or something that would be available? Yeah, I know a lot of apps that are free have a lot of advertising attached to them. So if anybody has a suggestion, they're welcome
I
to
have
put
one.
it into
Has
the
anybody
chat
seen the
box
Carrot
there.
app?
And,
It's called Carrot.
oh,
It was developed by Mark Mitchell from Western University, so not that I'm advertising or anything, but it's a Carrot app, and it's really interesting because it is more of a carrot for physical activity. Anybody can download it, anybody can use it, and it's linked to a point system for scene points or Petrocan points. So there is this Carrot app that you can download onto your phone, and it does count steps. So, and it does have kind of interesting little tidbits of information that you have to do a little test to see if, in fact, you are knowledgeable about physical activity. So it's interesting. Try it out. I'm not saying whether it's good or bad. I'm just saying that it's out there, but it's something potentially that you could use.
And my understanding, some provinces have really bought into that and made
Yes.
them sort of almost provincial.
Yes, and I think it started in BC.
Ontario.
I think it did start in BC when Mark was out in BC, and he's moved it and adopted it very nicely into Ontario.
And we have another good question from Lambton Public Health, that in the summary of the Canadian guidelines, the number 1 states that previously sedentary women with healthy pregnancy can safely start an exercise program in the 2nd trimester. Now, does this mean it's safer to start in the 2nd trimester?
I'm just going to qualify that, kind of what I've said previously, that if you are prescribing exercise in the 1st trimester, you don't want to overly fatigue her. So that is up to the healthcare provider. If she doesn't have morning sickness, if she's okay with that, she can start in the 1st trimester. As long as she goes slow, for example, she can start walking in the 1st trimester. That's not a problem. But it's just looking at those guidelines where we're talking about 60 to 80% of peak oxygen consumption. Starting slowly in 1st trimester is probably best. It's just a precautionary note. Also, if I can add to that, 1st trimester, if pregnant women have been used to exercising all the way along and they're not feeling overly fatigued and they actually are feeling fine in 1st trimester, they can continue their exercise program as long as it's within the guidelines.
Okay, thanks. And you can see the next questions. It sounds like, yeah, the American recommendations might be 20 to 30 minutes for most or all days of the week, which is a little bit different than Canadian. Or I'm trying to remember exactly what you said earlier.
Yes. So
can you clarify
the
that?
American guidelines do not have a proviso on what intensity means. So in Canada, we are a bit more anal, if you will, where we have actually taken a closer look at the literature, and we've actually developed these intensity guidelines and using 3 ways to confirm intensity. And basically, the reason why the ACOG actually dropped their intensity to 20 minutes was because nobody, well, I shouldn't say nobody, but you saw what it was like for women to engage in being physically active for 30 minutes. And so they dropped it to 20 because they felt that 20 is better than nothing. And so if we can get pregnant women to engage in even 20 minutes of being physically active, that's better than not doing anything at all. So that was the reason why they dropped it to 20 to 30 minutes. And they do suggest most or all days of the week, because when you look at potentially, say, 150 minutes per week, you can actually divide that up into every day. And again, these guidelines are more substantial, if you will, or they're more general, if you will, because many pregnant women are not engaging in physical activity. And so that's why they're trying to get pregnant women to be active at least 20 minutes, at least for most or if not all days of the week. But again, I come back to our guidelines where we have a cautionary note with regards to doing too much. We don't know where that threshold is, where there may be too much physical activity, especially with the elite athlete, with the higher end of women who engage in very vigorous physical activity. And so that's why we err more on the side of caution. We do provide duration, we do provide intensity, and so I think those are really important things that to provide for your pregnant clients, and that was why the ACOG came back with those particular more general recommendations. So I hope I answered your question.
Yeah, thank you. Thank you. Yes. And then there's one more comment question. Would you consider posting that Move for Two video to YouTube for greater access and to remove barriers? And the person points out that, yeah, many young people don't have DVD players anymore. So I don't know if it's a copyright issue or what was signed with the pregnant woman that I featured in
I
there,
don't
but maybe you
know.
can speak to that.
I would have to contact my colleagues at the Middlesex London Health Unit about that. Oh, there's Deanna. I see. Hi, Deanna. I see. Yep,
There
Deanna
you go.
is from the
There's the
Middlesex London
answer.
Health Unit. That's awesome. So,
Exactly.
Deanna says, thank you for asking. Unfortunately, when we got original permissions from our actors, we didn't get online permission. Okay, so I don't know if that's potentially something that maybe worked on or not. But Deanna is the person.
Always hard. Always hard to go back and, that was done all
Yeah.
5, 6 years ago at least, and to go back and try to find all these people and have them re-sign a new release. And I suspect at the time, yeah, maybe it wasn't in the foreseeable future that there'd be so much interest, but there's nothing quite like that out there, I think. So
Okay.
can't get permission.
Oh,
Okay,
that's
no
too
more
bad.
Oh, that's sad. Well, there's a good little group project. Yeah. And while Deanna is writing her last comments, we're pretty much at the end of this webinar. I really, really want to thank Dr. Mottola to have explained everything in great detail. Obviously, she is the expert in the province and Canada on the topic, and it was so good to have you here. This is the fourth and last English webinar as part of the series. We are hoping to have funding next year to put on a few more webinars related to prenatal education. And I will be closing this webinar room shortly, and then you'll have an evaluation link. And please do fill out the evaluation. It really helps us to justify that, yes, this is a useful service, and we can do more webinars next year and the following years. And we'll also send a link to the recording for people who, maybe some of your colleagues that have missed it, or if you want to refer to it back later. But in the meantime,
Thank you very much, everyone.
Very much, Dr.
Take care.
Mottola. Take care.